Welcome to STI's presentation, Steps to Take in 2016. My name is Karen and I will be your host today. This webinar is approximately 30 minutes long and will provide information on what you need to do this year to avoid 2018 payment penalties under Medicare's 3 current quality programs. Today we will cover 2016 requirements for each of the following programs: Medicare's EHR incentive program, known as Meaningful Use; Physician Quality Reporting System, referred to as PQRS; and Physician Value-Based Payment Modifier, or VBM. I will also be providing information on how to obtain your QRUR, which stands for Quality and Resource Use Report. So let's begin with the 2016 requirements for Meaningful Use. Please note the CMS web address provided on this slide. This page provides very helpful information on the program, plus offers numerous fact sheets for you to reference to. I have listed a few of those documents here and would like to point your attention to the document titled Prep for EHR. This is a great document providing step-by-step instructions on both registration and attestation process. If you are a first-time participant in Meaningful Use, you will need to register to obtain your EHR certification number, which you will need at the time of your attestation. Attestation deadlines will be covered later in the presentation. So who is eligible to participate? Here is a complete list of eligible providers for each Meaningful Use program. Under Medicare, we have MDs, DOs, dentists, dental surgeons, doctors of podiatric medicine, optometrists, and chiropractors. Under the Medicaid program, there are MDs, DOs, nurse practitioners, certified nurse midwife, dentists, and physician assistants who provide care in a federally qualified health center or rural health clinic. There is no additional criteria to participate in the Medicare program. However, for Medicaid, you must meet one of the following criteria to be eligible to participate. 1, have a minimum of 30% Medicaid patient volume. Or 2, have a minimum of 20% patient volume and is a pediatrician. And 3, you practice predominantly in a federally qualified health center or rural health clinic and have a minimum of 30% patient volume attributable to those individuals. Note that CHIP patients do not count towards the Medicaid patient volume for the first 2 criteria. Medicaid requirements do vary from state to state, so please contact your local state health department for the details. If you reference to the Prep for EHR document, it has a link to additional information on the Medicaid Meaningful Use program and provides a list of web addresses for each state's health department. You may have heard that Meaningful Use is going away at the end of this year, and that is not exactly true. Medicaid Meaningful Use program will continue beyond 2016. There is still incentive money available. On the other hand, Medicare Meaningful Use is sunsetting at the end of this year, making way for the new merit-based incentive payment system known as MIPS. Under MIPS, the Advancing Care Information category is replacing Medicare Meaningful Use starting January 1st, 2017. Meaningful Use 2016 consists of 10 objectives and 9 clinical quality measures. You must meet the threshold for each objective to successfully pass in order to avoid future payment penalties. Here is a list of the 2016 objectives and their attestation requirements. All providers are required to attest to this single set of objectives, which has replaced the core and menu objective structure from previous years. We are going to look at the details of each objective in the next couple of slides. All exclusions will apply towards both Stage 1 and Stage 2 participants. Objective number 3, computerized provider order entry, does have a unique exclusion that only applies to Stage 1. Providers who have never participated in meaningful use will be in Stage 1. Returning participants are in Stage 2. Even if you report for 1 year and skip the next, you are still considered a Stage 2 participant. Objective number 1, protect patient health information. Conduct and review security risk analysis. You must attest yes to conducting or reviewing a security risk analysis and implementing security updates as necessary, and correcting identified security deficiencies to meet this measure. And you need to do this at least once within your reporting period. Objective number 2, clinical decision support. There are 2 measures under this objective. Measure 1, you must attest yes to implementing 5 clinical decision support interventions related to 4 or more quality measures at a relevant point in patient care for the entire reporting period. Measure 2, you must attest yes to enabling and implementing the functionality for drug-to-drug and drug allergy interaction checks for the entire reporting period. Any provider who writes fewer than 100 medication orders within the reporting period will be excluded from this measure. Objective number 3, computerized provider order entry. There are 3 measures under this objective that address orders captured in the EMR for medications, lab, and radiology testing. Measure 1, you need at least 60% of medication orders recorded in your EMR. The threshold for both Measure 2 and 3 are set at 30% for each. Measure 2 addresses labs ordered, and Measure 3 addresses radiology orders. Again, these orders must be entered in the EMR. If you are in Stage 1, you only need to worry about the first measure, medication orders. You would automatically be excluded from Measure 2 and 3. If you write fewer than 100 orders for either meds, lab, or radiology testing, in your reporting period, you would be excluded from the corresponding measure, regardless of which stage you are in. When I refer to a percentage requirement for a measure, it is the attestation threshold for that measure, which is numerator-denominator ratio. The denominator equals the patient encounter or visit, and the numerator reflects if the measure was satisfied. So, to give an example, if you see 200 patients within your report period and you capture medication orders in the EMR for 125 of those patients, that equals 63%. You would then meet the attestation requirement for Measure 1 of this objective. Objective number 4, electronic prescribing. More than 50% of all permissible prescriptions written by the provider are queried for the drug formulary functionality and is transmitted electronically. You are excluded from this measure if you write less than 100 prescriptions during your reporting period, or you do not have a pharmacy within your organization, and there are no pharmacies that can accept electronic prescriptions within 10 miles of your practice at the start of your report period. Objective number 5, health information exchange. The provider that transitions or refers their patient to another setting of care or provider must, 1, use the EMR to create a summary of care record, and 2, electronically transmit the summary to the receiving provider for more than 10% of transitions of care and or referrals. If you refer or transition less than 100 patients during your reporting period, you would be excluded from this measure. Setting of care is defined as hospitals, primary care practices, specialty care practices, long-term care, home health, and rehabilitation facilities. The summary of care must contain at least 3 of these required fields: the patient's current problem list, their medication list, and a list of their allergies. Objective number 6, patient education. You need to provide greater than 10% of all unique patients with an educational resource. To define unique patient for the purpose of this measure, the patient is only counted once in the denominator. Even if you see the same patient twice for a completely different reason and provide a resource during each visit, they would still only count once in the denominator for your reporting period. Objective number 7, medication reconciliation. You will need to perform medication reconciliation for more than 50% of patients who have been referred or transitioned into your care. You would be excluded if no patients are referred to you within your reporting period. Medication reconciliation is defined as the process of identifying the most accurate list of all medications that patient is taken, including the medication name, dosage, frequency, and route, and comparing the medical record to an external list obtained from the patient, hospital, or other provider. There does seem to be some confusion about this measure, so to clarify, it is not just a review. Here's an example of what I mean. You are treating an established patient that you have not seen in a year, and you ask if there are any changes in the medications they are taking, and you update their medication list in their electronic chart. This action will not satisfy this measure. The key to this measure is that the patient has been referred to you or is transitioning into your care. So if a patient is following up with you after being discharged from the hospital and you reconcile their medications with what you have on file for them, that will satisfy this measure. Objective number 8, patient electronic access. There are 2 measures that you must satisfy in this objective. Measure number 1, you need more than 50% of unique patients that you have provided an invitation to join the patient portal within 4 business days. Again, unique patient will only count once. And measure 2, at least one of those patients needed to activate their account and view their health information. The exclusions for this measure are on the following slide. The exclusion for measure 1 and 2 is that the provider neither orders nor creates any of the information listed for inclusion as part of the measure, except for patient name, provider's name, and the office contact information. If you read over measure 2, what this boils down to is more than half of your patient encounters are conducted in an area where over half of the residents do not have internet service available. This does not mean they cannot afford the service or the service is bad or they do not have computers, etc. It means there is no internet service available to even offer those residents within that area. Objective number 9, secure message. Any electronic communication between a provider and a patient or designated patient representative that ensures only those parties can access the communication. So to meet this measure, only one secure message needs to be sent by either the provider or the patient within the reporting period. The exclusion would apply if you have not seen any patients during the reporting period or there is no internet service available to those residents. It would be the same exclusion that I just explained for the patient electronic access objective. And objective number 10, public health reporting. You must meet 2 of the 3 measures to satisfy this objective unless you qualify for the exclusions. There are 3 measures that addresses that a provider is in an active engagement with a public health agency to submit electronic data from their EMR. Active engagement is defined as the provider is in the process of moving towards sending or is sending production data to the registry. So to show you are in the process of, you must register with the public health agency no later than 60 days from the first day of your reporting period to be compliant for this measure. You must also respond within 30 days to the invitation sent from the registry to begin testing and validation. Failure to respond twice to the invitation would result in failure to meet this objective. So Measure 1 addresses immunization registry reporting. Measure 2, syndromic surveillance reporting. And Measure 3, specialized registry reporting. A provider may report to more than one specialized registry, which would meet the required numbers for this objective. Prescription drug monitoring program and electronic case reporting registries are considered specialized registries by CMS. Each measure has 3 exclusion options. You only need to meet one of those options per measure to be excluded from the corresponding measure. Measure number 1. You are excluded if you do not administer any immunizations, or there is no registry available, or the registry is not ready to receive data. If an immunization registry cannot accept the data directly, but has designated a health information exchange to do so on their behalf, which is capable of accepting the data, you cannot claim the second exclusion option. Measure number 2, syndromic surveillance. You would be excluded if you are not in a category of providers from which ambulatory syndromic surveillance data is collected by their jurisdiction, or is in a jurisdiction where the public health agency is not capable of receiving the data, or is in a jurisdiction that the agency is not ready to receive the data. Again, you cannot claim the second exclusion option if a health information exchange is acting on behalf of a syndromic surveillance registry. Measure number 3, specialized registries. You would be excluded if you do not diagnose or treat any disease or condition associated with or collect relevant data that is collected by a specialized registry. Option 2 is if the agency is not capable of receiving data, and option 3 is the agency is not ready to receive the data. And since STI has partnered with Genesis Registry, provided by CE City, you cannot claim this exclusion. As I mentioned, Meaningful Use 2016 requirements consist of the 10 objectives we just reviewed and 9 clinical quality measures. You must meet 9 measures that cover at least 3 of the domains listed here: patient and family engagement, patient safety, population public health, efficient use of healthcare resources, clinical process effectiveness, and care coordination. There are no thresholds for the quality measures, so you can report 0 on those measures. Please visit STI website for a complete list of measures available, along with the step-by-step instructions on how to set them up in ChartMaker. The reporting period for Medicare, which is the time frame that you are capturing the data to meet the objectives and measures, varies from stage 1 versus stage 2. In 2016, all returning participants will report on a full calendar year. For first-time participants, the reporting period is a minimum of 90 continuous days between January 1st and December 31st. For Medicaid, the program, it varies from state to state, so please go to your local state health department for details on reporting. Returning participants who successfully demonstrate meaningful use for 2016 will avoid negative payment adjustments in 2018. You must attest by February 28th of 2017. So you have from January 1st to February 28th to submit your attestation. New participants who successfully demonstrate meaningful use for this year will avoid negative payment adjustments in 2017 as well as 2018 if you successfully attest by October 1st of this year. This may be applicable to some of our clients who started meeting meaningful use requirements earlier in this year. For others, if you successfully attest by February 28th of 2017, you will avoid the negative payment adjustment in 2018 only. Moving on to the next program, PQRS, which stands for Physician Quality Reporting System. PQRS will sunset at the end of 2016. Aspects of this program will fall under the Quality Performance category of MIPS. Again, MIPS stands for Merit-Based Incentive Payment System, which is starting January 1st of 2017. PQRS is a quality reporting program that encourages individual professionals and group practices to report information on the quality of care they provide. Here is a list of eligible providers for PQRS. Now, I'm not going to read through this list, but as you can see, there are many more medical professionals who qualify for PQRS than for meaningful use. And there is no other unique criteria to participate in this program. You can report on individual measures or select one measure group. Thresholds for individual measures will vary, but most are at 50%. If you have been reporting individual measures via claims, you must do so for the entire year on all Medicare patients. You must be reporting on 9 quality measures that cover at least 3 of the quality domains. One of the 9 measures must be a cross-cutting measure. This is similar to the quality measures that fall under Meaningful Use Program, except for PQRS, you must report one cross-cutting measure. Starting January 1st of 2017, the new Merit-Based Incentive Payment System streamlines these programs to avoid such redundancies. If you have not been participating in PQRS for this year, and you would like to report to avoid the 2018 payment penalties, your only option at this point in the calendar year is to report on a measure group through a certified registry. You only need to select one measure group to report on. You report on 20 patients that fall into the requirements for that measure group. 11 of the selected patients must be Medicare, and the other 9 can be covered by any other insurance carrier. Measure groups must be reported through a certified registry. Please visit our website to obtain a complete list of certified registries. This slide shows some of the examples of measure groups available. And on the right is a list of all the measures that fall under the measure group for diabetes. The final quality program is the value-based payment modifier. And just like Meaningful Use and PQRS, VBM will sunset at the end of 2016. Aspects of this program will fall under the Resource Use Performance category of MIPS, starting January 1st of 2017. This program adjusts Medicare physician fee schedule payments to a physician or group of physicians identified by their TIN based on the quality and cost of care furnished to their Medicare beneficiaries. If you are not reporting PQRS measures, you will automatically receive negative payment adjustments under VBM. And if you are participating, you may receive an upward payment adjustment under this program. Eligible providers are the same as they are under PQRS. VBM is calculated on the quality reporting through PQRS and the cost or resource use, which is based on the claims you submit. The last topic of today's presentation is the Quality and Resource Use Report, known as your QRUR. Quality and Resource Use Reports contain information about physician performance on the quality and cost of care delivered to Medicare patients. The reports are intended to provide comparative performance data that physicians can use to improve the care provided to Medicare beneficiaries. Some of the information in the QRUR is also used by CMS to calculate the physician value-based payment modifier. You must first obtain an EIDM account in order to access your QRUR report. EIDM stands for Enterprise Identity Data Management. Please read the document, Guide to Obtaining a New EIDM Account, that is provided on our website before you get started. STI cannot help you obtain your EIDM account or your QRUR report. Before requesting an EIDM account, you will first need to determine which one of the following 4 user roles you want to request. For the group practice, there is the security official role or group representative role. If you are a group practice, you must first apply for the security role. Once someone is assigned to the security role, you can then authorize other users as group representatives. And for the individual practice, there is the individual practitioner role and individual practitioner representative role. And just like for the group role, the individual provider would apply for the role first. Once established, he or she can then authorize someone as a representative. Again, please read over that document before you get started and have all the required information ready before you begin the process. The document will list everything you need to have to be successful in obtaining your EIDM account. You have 25 minutes to complete each screen unless a different time is noted. Otherwise, you will lose all the information you've entered and you will need to start the process again. (2018) Payment Adjustments. The first payment adjustments under Meaningful Use began back in 2015 at -1% and has increased each year by 1%. So if you never participated in Meaningful Use, you are looking at a -4% payment adjustment in 2018. Under PQRS, the first payment adjustment also began in 2015 at -1.5% and increased to 2% for years 2016 through 2018. Now, for the value-based modifier, it will depend on your practice size. So in 2018, your negative payment adjustment for an individual provider or group 2 to 9 will be at 2%, and groups of 10 or more will receive a -4%. Here's a list of contact numbers if you need assistance with Meaningful Use, PQRS, setting up your EIDM account, the value-based modifier, and your QRUR. Please visit our resource section on our website for additional information. You can find a list of these documents as well as other information on these quality programs as well as MIPS. This concludes our presentation for today, but before we start our Q&A session, I would like to mention that STI is offering a MIPS assistance program. You will find information on our website and can register for a free webinar session that provides details on that program. These webinars will run until the end of August, so sign up now and hear what we have to offer you to be successful under the new merit-based incentive payment system. MIPS payment adjustments will start in 2019 and can be as high as -4% that year for those who fail to meet the requirements. And each year following, the percentage will increase. The three individual programs we discussed today, Meaningful Use, PQRS, and the Value-Based Modifier, are being rolled into MIPS. So we encourage our clients to participate in these programs not only to avoid 2018 payment penalties, but to be prepared for January 1st, 2017, when MIPS begins. If you had missed our webinar, Introduction to MIPS, there is a copy of that presentation on our website and a recorded session on YouTube. STI will continue our MIPS webinar series. At the end of September, we will begin looking at each of the performance categories of MIPS, starting with quality. We recommend that you review the material available on our website and attend our webinars to become more familiar with MIPS. After all, it is the new framework that will define your reimbursement. I would like to thank you all for your expressed interest and attendance to today's session.